This episode of The Dental Guys is brought to you by the Dental Crafters Network, your implant restorative connection. From surgical planning to patient-specific guides, quality implants, and final restorations, the Dental Crafters Network provides one relationship, infinite possibilities. Call 1-800-472-8302 today. You're listening to The Dental Guys, episode 47, Obturation Post and Core's Decision Guide. The Dental Guys finally put the seal on what was the longest root canal of their career, from obturation techniques to core buildups. And do Wes and John really believe in a post? This week, the rubber doesn't meet the road, it meets the canal on The Dental Guys. This week's episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy. And Wes, you shared something with me tonight before the show that really got us talking. And it has to do with some of the stuff we've been seeing lately in discussions about how to do things in dentistry. And Wes, share with our listeners what you shared with me, because it kind of messed with me a little bit. It made me want to talk about it for a long time.
It sounds dark and eerie, John, the way you describe it.
It sounds scary. Scary.
I'll tell you what's the problem today with anything that's going on, whether it be in business, whether it be in life, faith, making decisions is a part of life. Mm-hmm. And we have failed to teach critical thinking skills. And our comments that we see across as dentists toward each other, the way that we're lectured to, how we are taught, comes from a point of view that is very egocentric.
Which is kind of the opposite of critical thinking, right?
It is what you don't want to do. Egocentric thinking is an evil. And I'm going to read something. This is a book that I picked up years ago, back when I was in college. If you want to go to criticalthinking.org, you can pick up the book, The Miniature Guide to Critical Thinking, Concepts and Tools. I highly recommend it. But I'm going to read what egocentric thinking is, because I think most of us have been here or we are here. And when you make a comment like, well, it's just, I like doing it because it works for me, that's egocentric. As humans, we live with the unrealistic but confident sense that we have fundamentally figured out the way things actually are, and that we have done this objectively. We naturally believe in our intuitive perceptions, however inaccurate. Instead of using intellectual standards, John, in thinking, we often use self-centered psychological rather than intellectual standards to determine what we believe and what to reject.
Wow.
Some of the most common things that we say, it's true because I believe it. That's innate egocentrism. Number two, another thing that we say, it's true because we believe it. That's innate sociocentrism. I assume dominant beliefs within this group, so therefore I belong to this group, which have beliefs that are true, and I've never questioned the basis for these beliefs. Number three, it's true because I want to believe it, an innate wish of fulfillment. Number four, it's true because I've always believed it, self-validation, and you never question what you believe and why you believe it. It's true because it's in my selfish interest to believe it, an innate selfishness. So, since humans are naturally prone to assess thinking and keep keeping with the above criteria, it's not surprising that we as a species have not developed a significant interest in establishing and teaching legitimate intellectual standards. It is not surprising that our thinking is often flawed. We are truly the self-deceived animal. John, we need to be critical thinkers as dentists. We need to be a critical thinking, because critical thinking is, in short, self-directed, self-disciplined, self-monitored, self-corrective thinking. It presupposes assent to rigorous standards of excellence and mindful command of their use. It entails effective communication and problem-solving abilities and commitment to overcome our native egocentrism and sociocentrism.
So
we have to overcome these things.
Yeah, and this is basically, science is the opposite of egocentrism. Pure science says, I don't have any presupposed ideas. I mean, I might have a hypothesis, but I don't know anything unless I can prove why. And that is the basis of some of the best things we've ever done as a species, really. I mean, some of the best things we've ever accomplished have been because we've realized we don't know enough about something. And so we talk about dentistry to bring it home. We talk about dentistry and we say, why are we doing things a certain way? And on this show, we're always going to be about making sure that we don't care what people say. I mean, we care. We want to hear. We have people we believe, and if somebody says, some people we trust tell us something, we're definitely going to take that at face value to begin with. But you better believe we're going to verify that, and that's the thing that separates
John, that's
us.
what you just said there, is that you're not going to be a Kool-Aid drinker.
That's right.
Now, we know all kinds of Kool-Aid drinkers, and they're not critical thinkers. They're followers. Now, I'm not saying you can't be a follower as long as you critically and self-assess,
right,
and critically think about what you're following.
Just remember what you were hopefully taught about what science is all about. And remember that as doctors, as dentists, we are at the very heart of it. We're scientists. We are using data that has been collected by those who came before us to help us make decisions. And then we are testing their hypothesis in the clinical realm and seeing if it works. And if it doesn't work, we reject it and we go back to the drawing board. So
that's right.
You have to be going into the clinical side of your practice with science as your guide. And if we're talking to our friends and we're saying, well, I'm just doing something because someone else is doing it, or because that's just what we do, or that's what works for me, we're not saying that that's not a starting point, but realize that you may be flawed and you may not know it. And we may be flawed too if we do the same thing. So it's just the basis of a lot of what the show's about. And I think in light of some of the just discussions that we sometimes see go on out there, where we hear people weighing in on things with no idea what they're really talking about, or no basis. And then we wonder why dentistry is becoming more commoditized. Well, guys, as soon as you want to complain about the business of dentistry, how about we figure out the fact that when did we stop being scientists? When did we stop being doctors? When did we just start doing things because it's easy? It's not easy, guys. It's not supposed to be easy.
It's not supposed to be easy. You're a doctor and you make the kind of living you have because you're supposed to be a thinker, not a doer. And
and that's what we're all about. And
that's what we're all about. That's what the dental guys.
And in this series with Endo, we've tried to follow with that as we're presenting through the phases of Endo. I know it takes a while to get through these episodes if you've been going along with us, because it's not easy. And the thing is, people want a cookie cutter recipe. That's not what we're here for. We're here to go through.
We're not gonna point out like, hey, step 1, 2, 3, follow me, and you'll get this right. That's not critical thinking, because in your practice on a day-to-day basis, when you sit down, the human body is a biological variable in itself. No one person has the exact same DNA. That's what makes life interesting. is
Yeah.
that there is no one person, 7-some billion people on this planet, John, and not one person has the same genetic code, and
Right.
therefore we have to be critical thinkers.
Yeah.
So,
And in this series, that's been our focus on Endo, has been, going through each step and analyzing what available information we have. We know we're just scratching the surface.
well, we're going to try to sum it up tonight, though,
But
right?
we're going to try to bring it tonight all the way through.
Let's finish this root canal,
Let's finish this root canal. As Alan, our good friend Alan, has said,
Hey, listen.
longest root canal ever. But I love you pointing out that critical thinking has got to be key.
Yeah. So if you're interested in this book, head over to criticalthinking.org. Click on their books. It's the top one there, Critical Thinking, Concept and Tools, the miniature guide to critical thinking. It's excellent. It's an excellent read. It'll make you read it. You'll have to sit down and read it like 3 or 4 times, but it's amazing.
So
Amazing.
let's finish up this root canal, as Wes said. And today on this show, our focus is on kind of the final steps: obturation, post and core, coronal seal, making decisions on how we finish up after the root canal. So let's dive right into this, because if you've been following our series, and we would recommend, if you haven't been up to this point, if you would, go back and listen, because you'll find that it'll make a lot more sense when we get to this point. So in our series, we've gotten to the point where we have disinfected, hopefully successfully, the canal. We've cleaned and shaped it, and we're ready to obturate. So let's begin by talking about the most common obturation techniques today. And there are really 4. You can kind of group these into 4 categories. And there's lots of different techniques in each one, but you can kind of say these are the 4 main ones. You've got warm vertical obturation, which is essentially where you're going to have some way of heating up gutta percha and placing it down into the canal vertically. So rather than doing the, one of the other techniques we'll talk about, which is lateral condensation, which most of us learned in school, this is condensing it vertically from the coronal portion down to the apical portion while the gutta percha is in a warm state, so it can be moved around. So we got warm vertical, we've got cold lateral condensation, which is what, again, most of us learned in school, where we're going to place a master cone, then we're going to use some type of spreader to essentially make space for accessory points. Then we've got carrier-based obturation, which is a type of warm vertical, if you want to call it that, I guess, because the gutta percha is warm, and you are using some hydraulic force to place it apically. And then finally, we have single cone technique, which essentially is just using a fitted cone to obturate the space without necessarily doing any type of compaction. Now, there are some variations where maybe you do some slight amount of compaction, but in its purest form, the single cone is just that. You shape the tooth with the specific file, and you have a matching cone that matches that file to be able to place into the tooth when you're done. So let's talk, Wes, about a comparison of these different techniques. Why don't you start going through a little bit of this? Tell us a little bit about the good old standard. Let's start with cold lateral and talk about what is some of the things that are good about cold lateral. What are the comparison of how it works? What does it do for you versus, say, carrier-based or single cone? Let's kind of talk through that and sort of flesh that out a little bit.
Well, I think the big thing about cold lateral condensation is it probably is one of the best techniques to begin with, because there's a lot of control, John.
Yes.
The master apical cone is typically fit to this apical third using a single cone. And that cone, if you remember, and a lot of you that are listening to this podcast, you've done cold lateral condensation. And typically in dental school, the reason why they use this is because it is easy to control. We can put a single cone that's matched to that apical third, take a cone shot to verify that we aren't blowing it out the apex, or that we're not too shy of the apex, and that we are just in the right position. We then apply sealer to that, and we'll talk about that later. But what is left, the disadvantage of cold lateral condensation is the cold lateral condensing of other gutta percha points. Mm-hmm. And this is the classic Christmas tree shot that you were always taught to take in dental school. You go ahead and you're taking another cone and you're stacking it in there, and you're putting that spreader in there, and you're working it down, and you're condensing it laterally against the other cone until you try to make somewhat of a homogeneous piece of gutta percha from that apical third all the way to the coronal portion, providing some coronal seal
Right.
At the the orifice of the canal. The disadvantage there is that typically, if you do cross sections of cold lateral, it's very difficult to see a true homogeneous piece of gutta percha. It has some voids in it. It's not typically.
Yeah, it's not very dense.
It's not very dense. It's not consistent.
Yeah.
It's not predictable. However, it does work.
Sure.
And it works well.
There's lots of good research on that.
Right.
For years,
it works well.
That's all we had, and a lot of the classic research was done with it, and done appropriately.
And to be honest with you, the reason why we had it is the technology was not available to make cones properly, gutta percha cones properly to fit the file size, the master apical file.
Right. And I think that's where kind of that next, the next generation from that was really, I think, more of the warm vertical technique, which started using some of the same ideas of having a fitted master cone.
Yeah, this is the touch and heat era. This is the era where you had a touch and heat.
Right, and of course this all came back from the kind of some of the classic literature on this was the Schilder technique, and basically the idea was that you would fit a master cone to the apex the same way, very similarly to how you would do with cold lateral, and then you would take your some type of heat instrument down into that canal, and you would sear off that master cone pretty deeply down, and then you would do the down packing, which essentially meant you would condense and you would down pack. Now there's lots of different ways to do that, but probably the most common or most classic way of doing that was the System B and Obtura. Well, you could do it with a flame, but I mean, I'm talking about adding more gutta percha after you do that. After you've seared it off, however you did that with the flame, with the touch and heat. Now you would come back and you would use something like an Obtura gun or Calamus flow or something like that, where you're basically backfilling with a warm gutta percha. And as you're doing that, you're condensing it down as you go. So like you said, Wes, that was kind of the way to take it up a notch, where you could get a more homogeneous,
super cool too, buddy.
And super cool, very homogeneous fill, a nice way to get voids, or if you did it right. If you do it wrong, you get a lot of voids. If you do it well, you get maybe no voids, and you can still get that condensation, and you have excellent length control. And around the same time that we saw this technique, this warm vertical, really getting popular, that was around the time too when we started seeing more carrier-based obturation. Wes, let's talk about carrier-based.
Thermofill, and some people called it thermofill, mainly because we didn't really understand how to properly use it. But there was a lot of good research behind thermofill. Basically, you had a plastic carrier that had gutta percha fused to the outside of it, and then you have this oven that's matched to fit for these particular cones you would buy, and the oven would heat the exterior portion of the actual carrier, which was the gutta percha, liquefying the gutta percha, and then you set the working length, and then over a period of about 5 seconds you seat the carrier into the canal.
Yep.
What you ended up with was a 3-dimensional fill that would create a very good seal. But was it any better? We'll talk about the comparison of outcomes in here in a little bit. There were some disadvantages to this technique because if you push too hard, you could end up with a big puff. If you had
easily extrude,
you could have a lot of extrusion. You could hurt the patient. There's some problems.
And you had this plastic carrier early on.
Yeah, so
where if you were concerned about post space preparation, was a little more challenging. There was a concern about retreatment for some people, feeling like that was more challenging. Although depending on who you talk to, some people don't feel like it's any more challenging. But there's definitely a little bit more concern about that plastic carrier. At least there was.
I'll never forget going to a Tulsa conference in Colorado one year, and it was also a ski conference, so that was awesome.
That's
and
rough.
You had morning lecture and then afternoon skiing, which is amazing.
It's rough, man.
It was so awesome. It was so awesome. So, yeah, it was a rough time too, by the way. But I'll never forget the guy getting up there and talking about how everybody makes a big deal about retreating these plastic carrier cases. And he just proved everything that I thought about retreats wrong. He said it's just all about understanding and the tools used to retreat these carrier-based cases. And then he went into the fact that most people that are using carrier-based are using it wrong, and here's how you use it. And so then I started to like think about this. So then that's when I started to move. I was frustrated with my endo at this time. I was starting to, research out where I should take courses. I took this course, then I took Endo Buchanan. And I'll never forget being in the hands-on session of Endo Buchanan. Of course, we have a big System B, an element system there, the Obturation gun. I mean, it's super cool, this stuff. And I'm like, this is like $4,000, and I'm a young dentist. Do I need to make this investment? So Stephen Buchanan is here, and I'm getting ready to fill my case. And I look at him. I said, sir, tell me how important is it that I buy this? This is his system. System B is System Buchanan. He said this. He said, look, for years I did single cone technique and had no problems. He said, sure. Do my 3D fills look amazing with System B? Sure, they look unbelievable. But are the results discernibly different? He said, I've yet to see that from a long-term perspective. And John, as we'll talk about here, the comparison of outcomes, is there a difference? But tell us a little bit more about single cone and what that means.
Yeah, of course, single cone is just, as we said before, it's placing a fitted cone right down in there without any type of or very little condensation, because the whole idea is that the cone is fit specifically to the apical length that you want. So you don't have to condense it. You don't have to do anything special. So essentially you're just buttering up the inside of the canal with some sealer, and they're placing the cone, and then you sear off the tip down to the orifice, and you're done. And, single cone originally, it's been done for a long time. It's not necessarily a new technique, but it kind of, I think, got a little bit of a bad rap with all of this other technology out there, because you had a lot of companies, let's be honest.
Well, they want to sell stuff, dude.
Yeah, single cones of gutta percha are not expensive, and they like the idea of selling expensive stuff, and that's not all of it, but that's part of it. And so they would kind of malign it and say, oh, well, what kind of, are you getting a good seal? Are you, they would sometimes show these like dye penetration tests, like on single cone, and you're not getting, maybe you're not going to get as many lateral canals, and they made a big deal about that.
It's not three-dimensionally filled.
Right. And then if you have like an isthmus, where is it, can you really get gutta percha in the right spots? But the single cone technique has, I think, become more and more common. Now, part of that is for the wrong reasons. Part of that is because people look at it and go, oh, well, it's just quick. I don't have to worry about buying technology. I can just, get this stuff in there. But there's also other reasons, which is good length control, very good length control. You get a nice looking fill on the x-ray the same way, very homogeneous, because you're not inducing any voids into it. It's very easy to place multiple cones at the same time. If you have a difficult anatomy on a canal, you can place two cones down into a joining canal, and it's much easier than, say, carrier based, where you can kind of block yourself out. So there's some advantages of the single cone technique. But like you said, Wes, really where the rubber meets the road is, what is the difference between these techniques? Because most people have heard a little bit about these, and interesting, right? Because Colleagues for Excellence, we've used that. We've cited that a lot because it summarizes a lot of the relevant research. And there was an update just last year, fall 2016.
It's really good. We'll put that folder. It'll be on our website.
And it was a really good paper that they cited, actually back from 2011, which was a prospective study, which we know, again, if you guys have been listening to the show long enough, we know that prospective studies going forward are much better studies than retrospective, because you're basically saying, hey, we're going to just try this and we're going to follow it as it's going, rather than just picking and choosing and excluding things. So they did a prospective study, and here's the quote right out of the article. Several of these techniques, talking about all the different types, even the paste only, because we didn't really talk about that, But even the sealer only technique, now that's a little scary for some people, but several of these techniques, it says, have shown comparable success rates regarding apical bone fill or healing of periordicular lesions. So a clinician may choose from a variety of techniques and approaches that works best for him or her. So just like we talked about critical thinking, you can say here that if it works well for you, there is research to back you up. Existing research directs clinicians towards preparation and disinfection of the root canal as the single most important factor in the treatment of endodontic pathosis, and no particular sealing technique can claim superior healing success. Now, doesn't that go against what some people preach on the lecture circuit, or what the rep will sometimes tell you?
Part of being a critical thinker,
what
I
you
think,
have to get.
is trying to look at what point of view is this person coming from, and what assumptions have they made? Are they are they coming from? Are they part of a sales team?
Yeah.
You know, are they? You know, is this something they've never looked at any other technique? Don't deny the science. The science is there. This paper proves it.
Yeah.
But I think it's important to point out a couple things, John, is which technique gives us the best link control compared to being time efficient.
Right, because the effectiveness is not we could say they're all effective,
right,
but only if each one is done perfectly, right?
Let's talk about length control. I mean, we want to control the length, you know, and I think it's important.
That's where you can mess up.
Right. Do we need to fill at the apex a 0.5 millimeter short, 1 millimeter short, or do we need to go ahead and blow it out the apex and fill it completely full? You know, we want it, you know, I think we
want to be able to control it.
We want to be able to control that. So which technique, John, gives us the best link control?
Well, I think any technique that doesn't involve a carrier, you know, gives you the best, because the carrier certainly has, and I like carrier-based obturation, so that's not a negative on carrier-based. It just is the truth, though, that especially when you start using it, you have to really be careful to not end up with overfilling, because there's a potential, there's a lot of hydraulic force, and you really don't know. Once that gutta percha gets warm on the carrier, it's a different dimension than what it was. So unless you're just basing it all on the length of the carrier, which that sounds great, except there's gutta percha at the end of that. So that just answers
the next question, John, is like that basically carrier-based obturation is the most technique sensitive.
I think it is. I think carrier-based, but I think you got to give a close second to the warm vertical. Because I think that in terms of technique sensitivity.
That's true, because you have matched, you know, carrier-based, explained a little bit here, is that you have, you know, basically carrier-based is either, you know, the new gutta core, which actually has rather than a plastic carrier, actually have, you know, an actual core of gutta percha surrounded by a liquefied gutta percha.
Beta phase.
And basically that's carrier-based. Now, when we talk about warm vertical, you know, we're talking about like System B here, right, John?
Right, or calamus, yeah.
And the calamus technique. And to be honest with you, that's very technique sensitive. And I think that those cases that,
there's some places where warm vertical, even though it's technique sensitive, where it shines. And that is if you've got a situation with a large apex, an open apex, where you're maybe plugging it with MTA. Now you need to fill a large space.
C-shaped canals.
Yeah, C-shaped canals, big, wide, young teeth.
This is exactly why you need to be taking CTs. Because if you're a general dentist and you open up a second molar on a lower jaw and there's and basically you see a C-shaped canal, you're not filling that using cold lateral. You're not filling that using single cone technique. You could try. And you might be successful because it's been done before. But I would hate to be in that situation where I have to go ahead and seal it up and send them down the road to the endodontist. Save yourself some time.
Right. Or like a huge immature pulp chamber, like on a number 8 or 9. You know, if you don't have a warm vertical system in your office, which I don't, I avoid those cases where I know that I'm going to have these gigantic pulp chambers and refer them. Yeah, because we're not equipped to handle those cases unless you have that, and you have to be good at that. And I would just encourage, I think Wes would agree, if you want to learn warm vertical, you got to go see Buchanan. I think he's the master at this.
He's the master.
And if you want to go learn it really, really well, it's worth it. So our recommendation, let's talk about, let's break it down, Wes. What are we going to recommend to somebody as far as what to get in their office if they're looking at a system?
John and I thought long and hard about this, and we like to give a little bit for beginners and then advanced. And so we feel like that based on current research, our recommendation is that, number one, single cone or cold lateral needs to be used for beginners, even to advanced, with single cone being the quickest and cold lateral being the most adaptive, simple technique. Now, we might get some rap for that, but I don't care.
Yeah.
And I'm willing to listen to people talk about this, but it's just not there.
We didn't say the fastest. We didn't say, the best for every case. We just said it's a technique
for
that
beginners,
and
even advanced.
They can adapt to a wide variety of teeth.
But for more advanced users, you've been doing endo for a while. You understand control. You understand a little bit more than the average Joe. For more advanced users, I think carrier base can be effective. We think that carrier base can be effective for many different shaped canals, and it's very time efficient. But it has a very steep learning curve, so be very careful. I will say that right now I am a carrier-based 90% of the time, okay? Now, and then before I was carrier-based, I was single cone technique. And for like 8 years, I used single cone technique and then went to carrier-based obturation. And I will say, John, the first probably 10 cases that I was carrier-based, I probably pulled out carriers and redid the case. As I'm sitting there, I was taking x-rays, verifying that I was doing it right. Sometimes I was overfilled, underfilled, until I learned how to do it properly. So it's not something that is for a new user, and but we feel like that it is for advanced users.
Yeah, and if you want to really have maybe the most adaptability of any type of obturation, it's probably warm vertical. I mean, if you really if you want to be able to fill any canal, any shape, any time, anywhere.
Also most costly.
That's true. It's worth looking at. And, we definitely feel that there are times where you can't do a case without warm vertical. So don't feel like you can just pick one of these and be able to do everything with it, because I don't think there's any one system, except for warm vertical probably, that you can do every case. So
John?
that's a great intro to this. If you guys are looking at a technique to choose, that gives you some starting points.
Yeah. Well, let's talk about sealers. What are some of the most common sealers out there? I think we have listed here that ZOE, AH26, AH+, BC sealers. This is the most common type of sealer. Still, this zinc oxide eugenol sealer are still the most common ones available today. And really, should we be looking at resins? Should be looking at, one of the top questions we get as dental guys is like, what about these bioceramic sealers?
Yeah.
Basically, it's resins versus ZOE versus the bioceramic. So, John, let's kind of get right into that. What should we be putting on our gutta percha?
Well, one of the things that I think is an interesting part of this question that you're asking is, there's discussions about whether some of these are kinder to the tissue, less post-op pain and discomfort. There's also a question about, are you going to get improved disinfection with certain types? There's a question about whether or not you're going to get the better seal over the dental tubules also. And I think that what we kind of got from this is, all of the sealers are cytotoxic until they set. Even the MTA-based BC sealer is still cytotoxic before it's set. So essentially what that means is anything you blow out the apex, it's going to hurt the patient, okay, potentially. Right. Doesn't matter what it's made out of. And the other thing that I think comes into play is, are there any studies showing that there is one sealer technique or one sealer type that is better? I think what we found as we did a lot of research on this was that the BC sealer, it's interesting. It's interesting because we know MTA is so effective, but it's really not yet had any research to show. And I mean, you're going to have people that'll argue with this, but if you look at the endo literature, and we're not endo experts in literature, but we did look at some good meta-analysis on this. there's not really anything showing it's more effective. There's some individual studies showing it works well, but it's not necessarily more effective.
It's not gaining you anything.
No. And so the question is, well, what should we look at in terms of the decision?
Well, John,
one thing that endodontist brought up to me on BC Sealer,
this is good,
is she said it's difficult to get it out when you're retreating a tooth, especially if you use the BC Sealer or the MTA-based points that Brasseler has that go along with it, because you do get some very hard setting. I mean, this is still a sort of a Portland cement-based material, so you're going to get a very, very hard set and very difficult to remove. So I don't like that, and I look at what is the thing that I like about ZOE. The thing I like about ZOE, zinc oxide eugenol, is that it's resorbable. It is the only one, I believe, and correct us if we're wrong, we looked at this, I believe it's the only one of the available sealers, unless there's one that we don't know about, that is resorbable by the body. Now, really, the truth is that if you leave sealer outside the apex, is it gonna reduce the long-term prognosis of a root canal? Maybe, maybe not. It depends on what's in the sealer, if there's bacteria in there or whatever. Mm-hmm. But I would say maybe not. But you know what? I just like the fact that I know that it's going to be gone, that sealer is going to go away. So I guess to me, Wes, I feel like if it's all about the same in terms of effectiveness, I like the idea of something that the body can resorb. Resins are not resorbable. BC Sealer is not really resorbable. And no matter how biocompatible something is after it sets, I like the idea the body can get it out of there. I mean, if nothing else, it looks good on an X-ray.
It looks good on an X-ray, right? So,
in a couple of years, if you do have a little puff,
I think it's definitive here. Without further talking about sealers, is that good old ZOE. It just works, and we like the fact that if you do happen to have a big puff of sealer, and it's ZOE, it's going to resorb. Yeah. Bioceramics.
That doesn't mean we're saying, all overfills are okay, or we don't care about overfills. We're talking if there's you got a little millimeter over puff, which is fine. It's going to go away over time.
And so, histology shows that, it's going to go away and it's going to be okay. But we're not sure about these bioceramic sealers. Now, here 5 years from now, we could look back on this and say, hey, we've got this new thing and it's better, and here's why. And we can see a percentage, increase in the effectiveness of the apical seal of a root canal or lateral canals or whatever.
But right now, it looks like they're all healing about the same.
They're all healing about the same. So what about placing sealer?
Getting the sealer in,
Yeah,
So
John
what do you do? What do you do, Wes?
Well, I'll tell you what I do is I do the old classic butter technique.
Butter.
Butter it up. I butter up after I've dried my canal, okay? So, MTAD goes into the canal, and then ultrasonic, and then I'm drying the canal with matched paper points. I get a dry paper point. That's my last thing that enters the canal that's sterile. And then one of the techniques, and I just picked up on this the other day that I do, and I forgot that I do it, is that I taught the assistants to fold back the paper point container, which is sterile, okay?
Yep.
They syringe the sealer inside that sterile sleeve where the paper points are, okay? Now, I don't know that this really matters, but that's just another piece of control that I have. I'm not putting it on a napkin. I'm not putting it on my endo ring. I'm not putting it on my endo sponge. I'm putting it inside that sterile paper point. I gather up a paper point and I rub it into the sealer, and I take it down into the canal and I plunge it in and out. That's the buttering it up, okay? And then I look physically down in there, and I look to see that when I pull my paper point out, is there sealer that's still on it? Because if there's sealer still on my paper point, then I know that I've effectively coated the canal walls, okay? And if there isn't, I'll add a little bit of sealer and go back until I effectively have buttered the canal. Now, some people, there's all kinds of ways, John. Some of the other ways is lenchulo. You actually take a special file and you put the sealer on there and you apply it to the canal
spin it down
with this spinning file. You can use, a 20 file, a 15 file. There's all kinds of ways. And some people even use the master cone. So the master apical cone, like on single cone technique, you could actually butter up the cone and place.
Yeah, just put it
sealer
directly
canal.
in.
Yeah, just
I do it pretty much the same way.
I think we're pretty much similar. On
yeah,
that.
I do take a second paper point typically for me. I'll put one in coated like you do. Look for complete coating of the point, and then I usually take a second one.
Right.
Just because I don't know. This is just something I do because I feel like over time it's decreased my overfills. I'll go in with a second paper point, and I'm looking on that one for there being also a kind of a uniform, very light coating of the sealer on that second paper point, which makes me feel like I don't have like a big pool down at the apex or something that I missed, because you kind of don't know when that first one comes out. You're like, well, I know I coated the walls, but do I have too much? Right. And maybe that's being OCD, but that's something that I do typically. And that brings us right to the question of, well, how do you figure out where you're putting the sealer to? So this is a very controversial warning. If you're easily offended by discussions of
critical thinking skills are required entering this zone.
Exactly. Be careful, because we're going to talk about where do you fill your root canal to? Where should you shoot for obturation?
Oh,
to
always
end?
Overfill, John.
Yeah, I prefer 5 millimeters past the apex. Yeah, I shoot for 5
or 5 millimeters short.
Yeah, so we know one thing, okay, and no one can possibly argue with this. We know gutta percha overfills are bad. They're bad for prognosis. They're bad for pain. They probably need to be retreated with some type of apical surgery.
Yep.
Now, we know also the best healing in terms of histology, this comes right from a lot of endo literature that we reviewed, comes from being just short of the radiographic apex. Now, that doesn't mean that you have to go there, but it appears that's where the best healing is. We're talking just short of the radiographic. Now, that doesn't necessarily... It was interesting the way they worded it, because you can tell how controversial it is, because here we are using... Didn't we get away from using the stupid radiographic apex, man? I mean, remember that whole discussion where they're like, yeah, so use an apex locator because the radiographic apex is not an accurate representation.
And then here we go, take a radiograph.
Now here we are going where colleagues of excellence are like, well, research shows that it's best to keep it just short of the just short. What does that even mean? Just short of the radiographic apex. So basically, they're not saying wherever the apex locator tells you. They're saying going back to like the caveman days. So I don't necessarily think that is a good scientific way.
No.
I mean, so what if you're slightly short? You don't know where I mean, if you've ever extracted teeth, right? And you establish patency, look for where the apex actually is. And the apex sometimes is at the apex, or not the apex, but look for where the portal of exit.
Hey, dental students, if you're listening to this right now and you want to reach over and strangle your instructor, reserve that for after graduating dental school, because you just have to follow, unlike critical thinking teaches, you just have to follow what they're saying to get out of school, and then go back and start critical thinking about this. But
so does it really matter? I mean, if you look at that and you go, well, I know the portal of exit of the canal may not be where the radiographic apex is or whatever. I think the question is, should we, maybe this is the most important question, Wes. Yeah. How short?
Tell me, John.
How short can you go before it's an issue with success? Man. Should we shoot for a slightly shorter fill, or should we shoot for the radiographic apex or just short of it every single time?
Well,
and why would you do that differently depending on which obturation technique you're using? I mean, Wes, what do you think?
Here's the thing, John, is that research says that overfills are bad.
Yes.
Okay. So if we're going to make a call, we're going to say we want to be right just short of the radiographic apex. Okay. Now, even if the short, even a slightly short fill is still, from what the research tells us, is still better than an overfill. Because here's the thing, guys. If you have established patency, okay, which means basically you've worked your files and you're patent throughout the entire root canal procedure, you have flushed and cleaned and disinfected, and if you're slightly short, it's not going to matter.
Right. Shouldn't matter.
It shouldn't matter.
There's no bacteria down there
Now, if
anyway.
you have any
very
doubt,
few.
if you're a beginner, take a cone fit shot and realize, too, that the cone fit shot may not be indicate the true apex of that root because the radiographic apex does not match. But if you think there's some reason you feel like I'm just not right, just take a radiograph.
But let's get down to brass tacks, though, Wes. I mean, you and I...
The buck stops here.
You and I don't typically take a cone fit shot because we use this thing called an apex locator.
I believe the apex locator more, and my friend in dental school proved it.
Yeah, we know. We know this.
It's right.
So I would rather have my fill go to what the apex locator says is the apex, and I would go, if I would typically will set it about 0.5 from the radiographic. And there's also discussion, and we don't want to get into the high weeds on this, but there's also discussion about the fact that if you're treating a vital case, that you can probably short fill as much as you even freaking want, man, because who cares? It's vital. There wasn't bacteria in there.
Yeah.
But if you're doing a necrotic case, probably it matters more that you do obturate.
But
maybe
at least you're
canal.
using MTAD or you're irrigating that canal more than 40 minutes. So,
but I think that we got to just say, if you want to use the radiographic apex, that's great. Research supports that. I think if you want to use the apex locator, I think it's a more accurate representation of where the apex is.
I agree.
And in the end, Wes, if I have let's just talk about puffs for just a second, because we got to.
Puff the Magic Dragon.
Puff the magic. Yeah. So if you have
lives at the apex.
He lives in the apex. Oh, man. But if you have a little puff of sealer, and I'm talking when I say little, because people are like, oh, it's just a little puff. There's like 7 millimeters of it's a huge like tree. It looks like a giant live oak tree. But if you only have like a millimeter, I don't know how to define. There's no definition. But if you have a small little puff, like a millimeter or less, half millimeter, I am not worried about that. Now, gutta percha is different. You got gutta percha coming out the apex, dude. You better talk to your endodontist, okay? And you better not. You better tell that patient there's a problem.
Yeah.
But if you're talking about a little bit of a sealer puff, we know if we're establishing patency that's going to happen from time to time. Because you got hydraulic force pressing on this sealer, which can be pushed out. So it's a very controversial area, but I think the main thing is that if you're getting overfills routinely, you need to do something.
Yeah. As much as I'm excited about root canals, John, and here's the thing is like when I take out teeth to place a dental implant, most of the time I'm taking out a nasty tooth that's been root canaled. And a lot of times I pull these teeth out and they have overfills. And guess what's hanging out the end of the apex? A little tiny piece of gutta percha.
Yep.
And that's bad. That's really bad. And
it may contribute to why we're having to take teeth out and put more implants in.
I tell you what,
it's a perfect segue into talking about implants for just a minute.
And I'm going to throw this pictures. If you're listen, pull the car over, stop what you're doing.
Turn off Netflix, whatever you're watching.
Turn off Netflix while you're listening to this.
Westworld,
hey, listen,
whatever.
Pull your lawnmower to the side, open up the YouTube app, and go to this portion of the show and look at this picture right here. John, what I'm showing is a picture of a perfectly drilled hole through the center of an upper molar that needed to be extracted because a retreat was not possible.
It's a human drill press.
Yeah, the human drill press.
Job.
This is me.
Nice job.
I have this kind of skill to be able to do that.
Amazing. It's amazing.
Basically, what you're looking at here is tooth number 3 with a perfectly centered hole right in the center of the furcation of this tooth. Okay? Now, the tooth's cut off from the top down. And then the next picture you'll see is the actual furcation with the roots removed. And then the next picture you'll see, John, is an implant right in the furcation. And then, John, what we're seeing next in this next picture
it's the kicker.
Is the kicker.
What is that?
This is a custom healing abutment. Titanium.
Now wait a second.
Titanium.
It looks to me like what you did there is that this custom healing abutment had to be, it's titanium. It's not one you made.
Yeah, if you follow
direct.
our Facebook page, you saw one that I posted the other day that was made out of PEEK. Okay, go back if you haven't seen that and check that out. No, this is
titanium. Something that someone made.
Now, we're not talking about these two-piece type, okay, that I milled out in my lab. This is a solid piece of titanium that someone made. Guess who made this, John?
It looks to me like it came from the Dental Crafters Network.
The Dental Crafters Network. John,
this is a classic example of restoratively driven implant placement, because if you look at how this case works, this was something where we take a CT, we merge it with a model, we look at the cervical contour at the gingival margin on the CT, and we copy that into a piece of titanium, a customized healing abutment. And then after Wes human drill presses or guides the implant into place. This is guided. Okay, we let the cat out of the bag. It's guided. That's why it's so good. But so he places it through the guide so he knows, because you got to do that. If you're going to make these prefab or beforehand, you got to have a guide, because you need to know that it's going to be in the right buccal lingual mesial position for the healing abutment. So you put the implant in. Now, if everything goes as planned in terms of torquing this thing in, you pull out of your package this beautiful, it's even pink, man. I remember you made the comment the other day about one of and you know who I'm talking about, from Germany, who said, you dentists over there, you want all these color-coded things. Like, what's wrong with titanium? You know, you got a problem? You guys need everything to be color-coded?
Well, you know,
but I like colors.
You know,
I like colors. Because look at this, Wes. It even looks pink. It even looks pretty. And so you put that thing in, and when this goes in, tell me how it feels when it goes in, because you put a graft in there sometimes, or maybe you don't.
Right.
But when it goes in, how easily does this go in? Does it bind?
No, it doesn't bind. It actually seats down into the implant perfectly, because it's rapid, precision, guided surgery.
Which means that it's guided depth, angle, and even hex timing can be guided with this.
It's unbelievable what system they have over at the Dental Crafters Network. If you're interested in doing a procedure like this and provide you with the system, the protocols, the abilities to be able to provide you with to be honest with you, a very economical custom healing abutment, graft containment at its finest. I showed this to a colleague. John, should we mention the name?
Maybe not.
No. But
it's somebody really big.
Somebody really big, and they said, this is what I'm talking about.
Yeah, this is where it's at.
They said, who did that?
They wanted to know who did it and who made it.
Right.
And we've got people showing this. I saw this presented at a major implant meeting with this exact system being used with a custom healing abutment prefab. And these are not that expensive.
Listen, I'll tell you right now, if you're interested in doing this type of thing, we really appreciate the Dental Crafters Network, and they're sponsoring this show, The Dental Guys, this episode of The Dental Guys. Listen, from the planning, from the implant to the restorative part, they have it all. They have the whole package. Listen, the Dental Crafters Network is who makes this possible. In fact, their tagline is provides one relationship, infinite possibilities. John, I think that if you're interested in this, you need to go over to the Dental Crafters.
Go to Dental Crafters, dentalcrafters.net, dentalcrafters.net. Check them out. See what they can do. It's a bunch of different companies all together that make this possible, from the guiding to the implant itself to the actual lab that creates the restoration at the end. But it's all part of one network, and you can also call them at 1-800-472-8302, 1-800-472-8302. That's the Dental Crafters Network. We'd love for you to check them out, and tell them when you call them, if you heard it on the show, please mention the Dental Guys, because I can't promise they'll give you anything special, but they might. I don't know. But just tell them that we told you, because this is quality and you guys know we're all about it. So if we can help them, they want to help us get our message out. We want to help them to get their message out.
Hey,
so let's get back. Let's get back into Endo.
The show. Okay. What about the most important part, John? Because I'm going to be honest with you here. Is I feel like that this, and this is, we're going to rant here in just a little bit more, but I'm going to tell you right now, I feel like that when I was a sucky endodontist.
Oh.
Yes.
It's getting
when
personal.
I was struggling.
Yeah.
When I did cases that I thought, man, I did this and it's okay, it's not great, but they're still working. Why are they working? It is because of this crucial thing called coronal seal. Listen, coronal seal is the reason why bad endo doesn't fail.
Yep.
I think it is.
And it's supported by a really classic article in the endodontic literature that's written by people that you should know if you don't already know. There's a couple of guys that do a lot of research on bonding, Pashley and Tay, and they got together with some endo people, which isn't their typical group that they work with, back in 2011, Journal of Endodontics, and they published an article titled "The Impact of the Quality of the Coronal Restoration versus the Quality of Root Canal Filling." So say that one more time: impact of the quality of the coronal restoration versus the quality of the root canal fillings on success of root canal treatment, systematic review. So here's their conclusion. We'll try to break it down. So they looked at adequate root canal treatment or inadequate, and they looked at adequate restoration or inadequate. Okay, those were their groups. And they combined all those groups together, all the different combinations, to see what would have the most effect on success, on healing at the apex. And they said, although poor clinical outcomes may be expected with adequate root canal, coronal restoration, and inadequate root filling, adequate coronal restoration, there is no significant difference in the odds of healing between these two combinations. So just hold on just a second.
So everything we told you previous to this matters not, John?
So they're saying that it is basically the same if you do a great root canal, but you have a crappy coronal restoration, as if you did a great root canal and you had if you have a horrible crown on top of a great root canal, it's not a great root canal anymore.
That's right.
If you don't seal it well, and vice versa, you could have the world's worst root canal and it's still healed well, oftentimes, if you just had a good coronal seal. So essentially this is saying the coronal seal is as important, maybe more important, but at least as important as the quality of the root canal fill. And that is like, dude, we got to make sure that we're actually getting a good coronal seal. So let's go through some ways that we can do that. Wes, how can we get a better coronal seal after we complete our obturation?
Well, the first thing is cut your gutta percha off at the orifice. Yeah, dentist out there, myself included. How many times have I taken an old crown off or gone prep through somebody's, core, and there's gutta percha like 1/4 of a millimeter under the core, and it's completely filling the chamber. Mm-hmm. Remove your gutta percha down to the orifice. Then the next thing we can do, there's 3 different ways that we can do this. Well, we can do a composite buildup, something like Luxacore, something like whatever buildup material you want to use. You're going to be doing some etching and bonding, and you're going to basically, it's a mechanical retentive thing, but you're going to put something down in this. Whether it's amalgam worked great for years. It could still work great. If you want to put amalgam in there, great, do that. But I use a composite buildup, so does John.
Yeah, and I think you get the best. If you're going to do amalgam, make sure you put something in there that gives you a seal under it immediately.
Yeah, I think you need to use amalgam bond or something like that.
Some kind of glass ionomer.
Yeah, glass ionomer is great. What about just going ahead and doing your crown at the same time? Do the buildup and the crown. Dude, let me just say right now, if you're out there right now and you're doing root canals and you're not doing your buildup and crown at the same appointment, you're missing out on saving some cash.
It's the best day ever.
It's the best day
If I come in at 8 o'clock and I see on the
root
schedule...
canal core crown, baby.
root canal number 20,
Yes!
build up and crown. And I scheduled 2 hours for that.
You're
Okay,
done in
I
an hour
scheduled
and a
my
half.
office, and I'm done in an hour and a half, and it's 30 minutes of assistant time usually. So I do a root canal, I do a core and a crown at the same visit. It's good for everyone.
Yeah,
It's
because
good
now
for
the
me.
patient has to come back one more time.
Right. Patient loves it. They get the best coronal seal right from the beginning because I now have a buildup and a cemented crown, 2 levels of protection.
Yep.
I get to have complete control because I'm doing my core under rubber dam isolation. That's pretty sweet.
Yeah.
I also have a situation where I'm producing per hour the most that
man.
you can probably produce per hour, even better than implant dentistry in the amount of time that you do it, given your overhead.
It's amazing.
And you get very, very efficient. And also too, you don't have to come back and prep your tooth down. You remember in dental school, you know, you'd spend 3 hours putting in this like MODBL
Carving it all up.
XY,
Oh,
huge
man.
amalgam, and it's like the most beautiful thing you've ever created. And they're like, okay, well, son, that's a great job. You're going to be coming back next week, and you're going to prep it all the way into a crown. You're like, oh my gosh, I want to die. And what, you know, I have met so many young dentists, believe it or not.
They don't even know that this is possible.
They are still doing this. They're still building this beautiful buildup
Why?
after they do the root canal, and then they're coming back the next like week and they're just prepping it all away.
Let me tell you what not to do. Let me tell you what not to do. Let me tell you what stop doing. Stop.
Here we go.
Let me just tell you again. I've
Bring
already
it.
told. It seems like that's all I'm doing this episode is telling you.
This,
what
let me
not
just
to
say,
do.
guys, let me just say,
Stop being an egocentric thinker.
in the
Stop.
production notes, this next part is in all caps.
Yeah.
Okay, so go ahead, Wes. Bring it.
Stop temporizing with crap temps that don't seal worth anything. John, temp, term, whatever you're temping with, stop it.
Stop this crap.
Stop it. Okay, here's the thing. If you put obturation material and you take it out, if you obturate, please throw some glass ionomer in there. Throw it all. Don't you just throw some glass ionomer. If you have to put a sponge in and come back, put a sponge in it and put some glass ionomer on top of it. Don't use term.
Do something.
Don't use anything but some type.
Don't put a stainless steel ion crown in there. Don't do that.
Do
like,
a
don't
bonded
just put some
composite, or at least do some type of Fuji material.
right.
Some
Not
type
cavet.
Of glass. Listen,
Don't do cavet. Cavet should be gone.
Done. Don't buy the cavet in the caps that using a triturator. Don't have your assistant hand mixing on a glass slab. Stop temporizing.
Just stop, man. Just stop it.
Stop it. Okay, and here's why. Because look, one time your patient is going to come back and you're going to look and you're going to say, "Where's your temporary?" Oh, it's gone. You
Been
have
gone
a
a couple
moral
weeks.
decision right now.
Oh man.
Do you retreat or do you go ahead and do a build up and crown the case
And pray.
and just pray? Let me just tell you right now, good dentistry is a moral issue, and you better stop temporizing, because here's what patients do when they have root canals. They get out of pain. And when they get out of pain, they forget about the crown.
Yes.
And so go ahead and throw some core in there if you don't have time for the crown, and bring them back. But you make sure you tell that patient, hey, look, I put a temporary bonded filling in here. If you bite down on anything hard, you could break your tooth, and you just...
No warranties.
There's no warranties. Zero.
Yep.
There's
So
no
you prep
warranties,
that
because they
crown.
always ask me, John. They always ask me. They say, well, how long do I have?
How long can I wait?
Well, you have until you walk out that door,
Right.
because I don't know. So don't eat on your tooth.
Yep.
Because I can't even promise it'll be okay. No, I don't tell my parents. I don't tell my friends these different stories like, oh, you can wait 6 months. No, I told a friend the other day. He said, Wes, I had a root canal at an endodontist office, and he put a sponge. He said the word sponge because that's what the endodontist did. And he also put a temporary material over that. Can I delay having the crown done? I said, no, you need to run to your general practice and get it fixed. He said, so I don't need to put it off until next year? I said, no, you don't. I said,
No.
the least you need to do is go in there and have a permanent filling put in place that can be underneath the crown.
Yeah, or at least a provisional crown.
Right.
You know,
So-
if you have to wait on something, at least put a provisional crown on there with maybe a
goes on to the
long-term
next
cement.
point, John. Is the thing about the next point is, like, you need to discuss when you make a referral with an endodontist, and I've done this. Now, I like control, okay? this is me being egocentric, okay, is that I like control of the core. Okay, my endodontist years ago, one day my patient showed up and there was a core in the tooth already. And I'm like, is this good or bad? I sent the patient there for a root canal without knowing the extent of the decay or having the silver filling. Listen, the endodontist does not have time. They will not remove all of the decay. They will not remove all of the silver filling. They will not remove all of the bad tooth structure. So you don't know if the tooth is restored.
Yeah, I mean, you can't assume that. I mean, mine does, but you can't assume that.
Right. You can't assume because they all don't, John. They all don't.
Yeah, I know. That's what I'm saying. You can't assume that,
so
that you know.
You need to have this conversation. You need to have this conversation because you could be restoring a non-restorable tooth that a patient already spent $1,300 on having a root canal done. Okay?
Yep.
So have a conversation about who's going to be doing the core, the endodontist or you, if you're referring. And if you're not doing the core, okay, then you need to iterate to the specialist that, hey, look, please assess the restorability of this tooth, and don't be afraid to just send that patient back to me and just tell them the tooth needs to come out and you need to have an implant.
Right. Because sometimes the endodontist thinks that they don't want to send it back to you saying it's not restorable because you're going to be upset. So you need to be the one who establishes what your criteria are for restorability. Now,
John,
I mean, this should be pretty universal, but the truth is it's not.
It's not.
So you need to tell people,
just
hey,
have a conversation.
Just have a conversation. Hey, if we're talking about, you can see light through the, the furcation, or if there's, like
if there's decay in the furcation, then
if I have to put 6 posts in to retain my core, maybe it's best. Maybe it's best to not do that. And so, and then the main advantage of the endodontist doing it is that they get to do it under isolation. So that's nice to get rubber dam isolation done for your core. But I would say there that if the endodontist is doing a good job, they should be able to put a little bit of like a glass ionomer lining in over your canals, throw some cotton and some Fuji-9 in there or something, send it back to you. You can do the core. I like you say, Wes, I like the control over being able to take everything out and really assess the restorability before I put my crown on there, because I have been burned before just like you.
Yep.
And I think it's something that one of the interesting things that kind of got us talking about this too, that it also is interesting because when you take out that temporary,
right,
and you look at the access. Now, if you're an endodontist, probably no endodontists listen to this. Maybe there's a few. I hope there are a few. If you're an endodontist and you're listening to this, this is your chance to show us how awesome you are. If you are the world's best endodontist, Cliff Ruddle tells this great story. He says,
it's so good.
He goes, okay, so when I did this, I wanted my general dentists to be able to see my access. He's like, I wanted them to take out that temporary, and I wanted them to say,
how did they
Cliff, how did you do such a beautiful instrumentation and obturation through such a small opening that's so conservative, and the glide path is just so... And he's like, I'm building my brand through beautiful root canal access that's conservative but yet effective. And so if I'm taking this core out, or I'm taking this temp out, and I see this blown out, horribly disfigured tooth. It's all, it's jagged line angles everywhere. There's like a little amalgam over in the corner still left, a little decay on the buckle.
I love whenever I get the letter and it says, I left decay in the mesial box. Please remove.
Yeah, you're like, what was your job, dude? Like, what did you do? What did you do here? Why did you do? So, and one other thing I'll just throw out there while we're on, I almost forgot to mention this. If you're using ZOE as your sealer, okay, just real quick,
wait
just
a minute.
as your sealer, remember what does eugenol do to composite bonding? It
calcium
screws it
hydroxide
up.
paste underneath my class 3 composites, John.
Yeah, well, but if you seal a tooth, remember to clean it out. Now, I did read an interesting article
about
just a couple months ago about what is the best material to remove ZOE or eugenol from a pulp chamber. The best that you get that's out there is isopropyl alcohol, believe it or not. So,
really?
if you,
that's good.
Yeah, so isopropyl alcohol was
Scrub
shown.
the floor.
Yeah, Exactly. And you just scrub it around, and you get and it took away the most. It was more than total etch. It was more than water. It was more than a couple of things they tried. Isopropyl. So just get a little cotton pellet, scrub it around in there. If you want to get the best bond, if you're using a ZOE, because that is an issue with ZOE. If you just put it right in there over the ZOE, you're not going to get a bond. So just while we're on that, so Wes, we mentioned just a moment ago. We mentioned if you have to put 6 posts in a tooth, you probably shouldn't be restoring it. And that brings us to the final topic of today's show.
Let me be the no guy. Let me be the no guy.
When do you place a post? So the question, I have one question for you, Wes, just to start this off.
Yes.
Do posts strengthen the root?
Well, evidently some dentists still think they do, even as recently as probably in the last 10 years, because I have a friend that had a tooth that turned dark, had a little painting above the apex of number 9, and I'm looking in here and I'm like, doing an exam on this person. I'm like, why is there a metal something sticking out of the back of the tooth that's polished to match the occlusion? I take an x-ray. It is a post in a tooth that has no decay. Do posts strengthen the root? No, they do not. No, don't put posts in teeth to strengthen them. Listen, I have a problem with posts. John has a problem with posts. Listen, only when it's the only option that you have, that's whenever you should be using post. Yep. That's whenever you should be using post. Listen,
or if you need to get them by for a while.
Yeah, that's the thing, is that these are like palliative care cases, and I know we're going to get some rap for this, but listen,
maybe.
And I'm fine with that, and I'm okay with that, because I truly believe it's all about the preservation of bone. And at some point, we have to let teeth get out of the way and let implants move in. Listen.
Yeah, so if you are looking at preserving the bone and you want to hold on to a tooth for a while because the patient can't afford an implant, or you're looking to give them a short-term solution, posts are great. And it's not that like every tooth with a post is bad, or we're like taking teeth out that have posts in them just because we can. But if you are, at what point, how many times do you get finished putting a post in and give the patient like good news?
Yeah, seriously.
Like, good news, we fixed your tooth. Dude, no, come on.
We had to put a rod down the center of your tooth to hold your crown on.
Yeah. We had to core out your tooth.
Just use your common sense here. It's not a good thing, and it never really has been.
And what is the long-term prognosis? I love this.
Yeah.
What is the long-term prognosis for root canal, post, and crown? 6 years. Average 6 years. If it's an abutment for anything,
it's done.
Fixed partial denture, or partial, it's 3 to 4 years. That's the research, man.
Stop just filling your chair with production.
Yes.
Stop just filling your chair with production.
And that maybe hits close to home for some of you people, because I know people who put them in. It doesn't have anything to do with this discussion. It's because they know they can bill the insurance company.
Yep. Listen, let me just say this right now, is that if you're doing that, you're malpractice. You're just.
Yeah, it's fraud, man.
It's fraud.
It's fraud.
So let me just say, if you do have to use a post, John and I recommend using a non-active or non-engaging post. Don't be screwing something down in the center of the root. Okay, basically a passive post. We've recently tried some newer posts from a company. 3M has passive fit post. Parapost is a passive fit post. There's many good ones. Just make sure.
Use something carbon fiber, glass fiber.
Make sure it's
flex
flexible
with the tooth, so that if the failure, you're hoping that the failure point is the post coming out,
not the
instead of the root fracturing.
Right.
Exactly.
Listen, always have at least 3 to 4 millimeters of gutta percha apically to the post. Also, make sure, if you're trying to get this patient by, that the post is halfway into bone. Now, you can't. If you start pushing the limits of that apical
and ideally that the post length is relatively close to the same length as your crown. That's a good rule of thumb that tends to follow pretty well. And make sure there's a ferrule, for goodness sakes. If you're going to put a post in there, and again, these are obviously sometimes heroic situations, but don't restore a tooth without ferrule. We know this. It's not new. It's not something we should have to tell you. Wes, how many times in a year would you say that you place a post?
Yeah, it's interesting, John. We talked about this in pre-production. You and I are
Yeah.
more similar than not on this, is that 1 to 2 times.
Yeah.
1
Twice
to
a
2
year.
times.
Twice a year for me.
A couple times
And
a
it's-
year. It's
and
usually,
it's usually
an
a
elderly
situation.
person.
Yeah, it's an old person who comes in with number 9,
they're
broken
like
off at the gum
95
line.
years old or whatever.
Yep, they're not healthy, and they don't want to do an implant and I feel good about it in those cases. I feel like I'm doing a good job. If I had to do that, I would do it. And if I had a patient who we had this informed consent discussion, hey, you can have a informed consent discussion. You can do whatever you want as long as it's informed consent.
Yep.
But don't be telling a patient the tooth's
We're for a good
fixed.
15 years out of this. Don't be telling a patient that. Like, look, this is a
it's not
5
fixed.
to 6 year fix. Maybe that.
And I would dare you to show me a number 28 or number 29 with the post that you have a 5-year follow-up on. Show me. I challenge Dental Guys listeners. Show me a 5-year successful follow-up on a lower premolar, preferably 29, okay, that has a post that has been successful for 5 years. If you can show that, I will send you.
It's been a while.
I will send you a candy bar of your choice,
Signed by John the Dental Guy.
By John the Dental Guy. I mean, or a T-shirt or something.
We'll
I'll send you a Dental Guy's T-shirt.
We'll send you a shirt saying you.
Because they don't
right.
exist,
we'll sign
man.
it across the back where it says.
I know I'm not
going to
be sending. I know I'm not going to be sending. Actually, what I'll do is I'll screen print a picture of that X-ray on a Dental Guy's shirt, and I will send, because it's just so. So just remember, guys, this Endo series.
Oh man,
we started off saying to you guys, if we're going to do this series, this is why it took us so long to do this series, because we wanted to do it right. We wanted to do it well. This show's run a little long because we had a lot to talk about, but we hope that this, if you have gone for a long time without doing endo because you were afraid of it, hopefully this has gotten you excited about endodontics again, maybe given you some ideas of how to get back into it. If you're just starting at a dental school, hopefully it's given you a starting point of what to look at next. If you're a very experienced endodontist or general dentist doing endodontics, we hope that it's challenged what you're doing. We know it's definitely challenged us to do some things differently, even as we've been researching for this show. We, as always, want to have you guys engage with us. We want you to let us know if what you heard today was something that's valuable to you. We want you to give us a review on iTunes. We want this dental podcast to be visible. We want it to be ranked highly so people know it's giving you value. We want you to give us some feedback on Facebook. We want you to hit us up on Twitter. And maybe more importantly, we want you to share this with friends of yours that you think would be interested in what we're doing. Because as we are growing as a podcast, which is getting kind of crazy, it's awesome. We want people out there to know that we are an authority that you listen to when it comes to making decisions about what you use, how you do things, and hopefully taking it to the next level. We have enjoyed getting to spend this time talking about root canals. We're going to be switching it up in some coming episodes to some new things. We may be coming back to some more endo stuff later, but it's been a great ride, Wes. It's really been fun, and it's been one that I think will definitely get a lot of traction for maybe a while on this series. So for Wes the Dental Guy, I'm John the Dental Guy. We are the Dental Guys.